do that again?
No, no. We introduced Brett. We all know how important he is. Amy's introduced herself. Got Jim. We know Jim's full name. And now we'll move to Tanya.
Hi, I'm Tanya Ferguson, and I am the Director of Quality Assurance and Compliance for DBH.
Risk management.
Risk Management. Sorry, it just changed.
She's
All right.
managing all our risks. So.
Okay. Well, she's an important one to have there. Jolene.
Good afternoon, Jolene Crone, Deputy Administrator, Clinical Director with the Salish Behavioral Health Administrative Services Organization.
Good to have you here. Lisa?
Hi, I'm Lisa with Health Facilities Planning. I think you met this Lisa. I wasn't sure if the other one's on. And I'm working with Amy on the data and analytics.
Thank you. Dunya?
Hi everyone, I'm Dunya. I work on population health initiatives over here at Jefferson Healthcare.
Thank you. Good to have you here. Dr. Carlbaum?
David Carlbaum, I'm the Medical Program Director for East Jefferson County EMS.
Good to have you here. Adam?
Hi, I'm Adam York with Jefferson County Data Analyst.
Thank you. Okay, so at the top of our agenda, I want to say a big thank you to Brett Anglin for running data for the Port Townsend Police Department. As you know, Chief Olson can't be here on this day, so we sort of circle back to him with whatever comes out of this meeting. I did not get any input to bring back to him, but Brett did run him a whole bunch of data, which I think he would have had a hard time getting without you. So very much appreciate that collaborative spirit. I think the first topic on our list is the update on code prioritization. And I'm going to let Amy and Lisa lead this conversation. And I'm going to throw up a slide at the same time. There we go. Everybody see? Okay.
So I will start. So my understanding is that this list under the EMS coding categories is what's available in ESO for the EMS providers to code patients under. That's my understanding. I could have that completely wrong, and we were asked to look at this as far as kind of prioritizing what items we would want to include in a data in our data gathering efforts. And one of the things when Amy and I was looking at it is, and I think one of the challenges that we talked about last time was for law enforcement, we get these kind of three major categories: alcohol, drugs, mental health. And we also know for each incident, whether someone has an alcohol incident and drugs, alcohol, drugs, and mental health, or what combination of those. And what we were really trying to see if we could get through EMS and the East Jefferson Fire Rescue, et cetera, was can we get not just their primary impression, but also some of the other comorbidities that they might be dealing with. And so when we looked at this list, we had a couple questions. One was, are these codes that they're currently using, that they're currently categorizing? And if the answer to that was yes, what we would love is some clinical expertise on where these would fit into how we could get this data and group them into these alcohol, drugs, mental health, if those are the right categories, so that we could have some consistency across being able to see, say for each incident, what are the categories that patient fell under. For example, I looked at sedative and Amy raised the question, does that mean they were provided a sedative for a mental health issue? Does that mean that they overdosed on a sedative? Just which categories would these things fit into? And then depending on that, what are the ways we could get that data back? If these were things that they already have access to and we could get those into categories, they could just give them exactly like that, and we could, do the data work of putting them into categories. So I guess just understanding more what exists, what we're able to get.
So Lisa, I also wanted to ask quickly, when you're thinking about this, are you thinking about just EMS, or are you thinking about EMS and law enforcement?
Well, so that's a great question, because I don't understand enough what everyone has access to, what coding they're using. My understanding is that EMS has a whole different system they're using than law enforcement. So that's why we were hoping if we could get similar broader categories. So
Right.
that we had, the broader categories, no matter how they were coding them individually, if we could have ways of rolling them into these broader categories. So we'd know if there was, this is probably not the right term, but comorbidities, or, we would know if it's just a pure mental health versus mental health, drugs, alcohol. So we could get more than just that primary top of the mind reaction from EMS and fire, which we do now have with Jefferson County and Port Townsend Police Department. We get them into those three categories and know if there's more than one. So that's a great question to hear. I'd love to hear EMS and Jefferson County Sheriff's Office talk about if these are, I don't know enough about to even know if these codes are something that people are currently using. So.
Great. Dr. Carlbaum?
Yeah, great questions as a data manager. This is the universe of codes that currently exist in the charting system. There are 5 fire districts in East Jefferson County. East Jefferson Fire and Rescue, which is the Port Townsend area, and Port Ludlow use a program called ESO. The Brennan and Quilcene and I think Discovery Bay, which sees vanishingly few patients, use something called emergency reporting. There is no standard work right now, and that's something that I'm looking to this group's guidance on how you want this set up. I think my hope would be that their impressions are sort of layered by priority. So for example, a suicidal human who cuts their wrist would be wrist laceration. Second impression would be suicide attempt. Third impression might be depression. The psychotic person who's using opioids to quell their internal stimulus might be opioid overdose because they received naloxone, secondary to maybe psychosis or psychiatric illness. And so there's some in here that make no sense to me. Most of these are not used. Mostly there's not been very much guidance. I think this charting system is relatively new to them, about a year, maybe 2 years, and I think they just try their best. I see a variety of codes used that I'm like, makes no sense to me. And so I think if this group can craft that, I'm not sure. While the simplicity you're lobbying for, which is just substance yes or no, I would actually like to have some drill down on opioids, right, as we do naloxone interventions versus other substances. I do wonder if EMS use a slightly bigger list, if we could pre-decide which ones got mapped to which bigger category, if that would be acceptable or not, and that you guys could do that mapping maybe.
That was one of the things, I don't think we were thinking that you would use the same list, but we would love guidance on how to group things into bigger categories. So we're sure we're capturing it the way that makes sense clinically. We don't have that clinical expertise for some of those things. And also, I don't know if there's, if we want to talk about getting some of the law enforcement data into some, more categories. So I don't know that those 3 have to be the buckets. We're just trying to see how much consistency we could create between, but we can take, if we know the mapping, if we know how you want them grouped, we can take data in whatever form is easiest and then be able to group them. We just would want that guidance from this group on the appropriate way to do that.
Yeah, my one advocacy for both the police and the EMS, fire EMS, is to make it as simple as possible for them. I think in particular for the police officers, they're also not medical providers, and I think asking them to find fine details is maybe a little too much for them. No offense, Brett, but just want to make it easy.
Yeah, and so I totally agree with that, and we're willing to take the data however we can get it, as long as we know that we're mapping it appropriately.
So when it comes to mapping, what is the next best step to make that happen?
I can help with that master list. It would be helpful. So I can only get that list out of ESO as a image of
Oh, I can
things.
totally develop it into a spreadsheet or something.
Yeah, if someone could just make a quick spreadsheet out of that, I'm so
I'll do that.
sorry. I could. I have like 100 things on my to-do list. That would be super helpful. And then if you had master categories, Lisa, maybe like a next tighter grouping and then a really simple grouping, I'd be happy to try to, just go through that list quickly and say, I think it should go here, and maybe have Dunia look at that or someone else who has clinical experience to double check my work.
Yeah, and I would love for people to also look even as we create those groupings to help us say that if that makes sense or not. So.
But it makes sense to start then between Amy, Lisa, and I getting that first setup of the actual list of what they are, and then to send it out to Dr. Carlbaum, and then from there send it to whoever else needs to sort of be involved in that gut check against what we put out as a first pass.
And then I think for me, my next steps would be, once that list is established, I'll go to all the fire districts and say, this is kind of how we want you to do this, and might have to come up with some definitions, which I can look broader across the state. For example, if someone is sleepy from using oxycodone, is that an opioid overdose, or is that opioid use disorder? Versus received naloxone because they weren't breathing. I think that's clearly an opioid overdose, but just some of those subtle things, and I'll just have to write some definitions for those that we all agree on.
Is there any way what we're talking about right here is going to impact, Jolene? I'm thinking about the R.E.A.L team, the thinking and the training that goes into our efforts to make some sort of standard approach. I recognize you're not in a medical situation, but I just want to make sure, as then we think about adding the R.E.A.L data, whatever it is, into this, that we've created some broad enough categories that we can incorporate R.E.A.L data as well, the R.E.A.L team's data.
I don't see why we can't meet some of the criteria. Again, we were just notified last week that they're changing our data. So again, we will be getting a new template within the next 2 to 3 weeks. That will be effective April 1st. So it's kind of hard to speak to what that data is going to be until we have it. I don't anticipate it's going to change a tremendous amount.
Well, I'm really glad you're here hearing the conversation, so you know our intent at the end of the day. Okay. Go ahead, Lisa.
I don't know, Lori, if we have time for this, but I don't know if anyone wants to just off the top of their head give us some. So we have alcohol, drugs, mental health is kind of the big categories. And then we have this long list that we had in the other. What are the other, for the medium category group, is there something like, what is it? Dependence versus overdose, does anyone have any thoughts on that other list that who's asking about related to not being quite as rolled up? And I don't know if anyone wants to shout some things out, or if that question even makes sense. Is it overdose versus dependence, and types of drugs? What are the kind of categories in between this list and our
high level
rolled up lists? Yeah. Anybody have any initial thoughts?
Don't everybody speak at once.
I say I feel like I'm dominating the conversation, so I apologize. I think opioids would be important. I think I would separate out THC because I think that's interesting, because there's all these elders in Port Ludlow who are experimenting with it and having challenges because they're dosing themselves wrong. Alcohol, methamphetamines, cocaine, maybe other stimulants. I don't think people use much inhaled agents, so huffing. I haven't seen people in Jefferson County. They're either getting their dosing correct, so they're not having to activate EMS, or their behavior isn't that bad, or it just causes their kidneys to fail, so they present in other ways. And then maybe poisoning or drug overdose, drug ingestion, for sort of Tylenol or pill overdoses. I think alcohol use disorder for the person who's intoxicated. I think alcohol withdrawal for the person who has alcohol withdrawal, right? They're, having a seizure because they haven't had alcohol. I would defer to people way more wise than me about anxiety versus depression versus psychosis, if we should even trust EMS providers or law providers to know what psychosis is. Not sure.
So this is Jim. I'm listening to what you're saying, Dr. Carbone, and I agree that some of these terms are really clinical terms, and especially when I see the word dependence. I mean, dependence is a clinical description of somebody's, and I don't know if you can determine dependent just because you see somebody that's intoxicated.
Yeah.
I think that's drilling way beyond the means of that, what you need, and stay away from those actually diagnosed terms that have a strict diagnosis, and maybe be a little more simplistic in the sense of somebody's intoxicated. What are they intoxicated with? Something along those lines. Yeah, I would have trouble, with even trying to look at anxiety versus depression. I mean, a person may report they're depressed, and that's all you can go by. I mean, you can't look at somebody and say, oh, they look depressed. I mean, that's not the way it works. So yeah, I just wondered about breaking it down to those levels. Maybe it's self-report more than anything. So, and what a psychosis is, obviously, some broad paintbrush kind of ideas maybe, but I'd be really careful getting into those specifics. So,
Okay, so just subjective things. So the
Yeah.
patient, like, auditory hallucinations, would that be okay if the patient says they're hearing voices?
yeah, I mean, I think you can report what a patient tells you. That's the best you can do. And I think that would make sense to me,
And for the patient that smells like alcohol who's passed out in front of the grocery store, would you just say alcohol intoxication?
I would over intoxication. Yeah. So yeah, obviously intoxication would be the best. I mean,
Okay.
it could be a one-time deal, and it could be, doesn't mean they have a dependence, and then even the difference between dependence and abuse. I mean, and I don't even know if those terms are used as much. I know they've changed some of those diagnoses terms in the DSM. So,
There's one coding I've seen in our diagnosis coding at the hospital that I liked. It's initial encounter versus repeat encounter.
Mhm.
I don't know if that would be helpful though. I kind of feel like it's important to distinguish if this is the first time this person's been had a
Yeah,
situation.
I'm not sure. I think it depends
I
on
don't
the
know.
connectivity of their tablet. Each of the
Oh, yeah.
ambulances serves as a Wi-Fi hotspot for their tablets. But if they're deep inside the grocery store, in the back of the Safeway, they may not have connectivity. So they may not know that the person has been seen before. In theory, if they open a new chart on a person, it should tell them if they've been seen before, but I'm not quite sure of the exact details of that. And I know connectivity is sometimes still a challenge.
And also, would it be worth, I mean, are there situations where someone's having a psychiatric episode and they're causing harm to other people? Would that be worth, like, how would that play out? Sorry for the dog.
Clearly, your husky is trying to answer.
It's a good one. I like that. Maybe is that a way to describe something, just as a psychiatric episode? And then is there acuity, severity levels of it? I don't know. I mean, to keep it simplified so you don't try to break down depression versus anxiety versus,
There is a category that's mental disorder that already exists in the chart. Like that seems pretty
antiquated
/ vague.
It's like if somebody's walking around the grocery store with a knife, they're just having a complete meltdown. Like, which one would we? Yeah.
Well, the question is it, I mean, I'll play devil's advocate. Is it a psychiatric episode, or is the person just wanting, I mean, we always
killer.
Yeah. I mean, we always look at people that just they got to be mentally ill to do that. And that's not necessarily true. So just being an advocate here. So.
Okay, do we have enough to go on to start, Lisa?
Yeah, I think that was incredibly helpful. That was the exact kind of feedback I was looking for. I think it's great feedback that we can't expect diagnoses in the field. That's excellent feedback. So yeah, that was very helpful. Thank you so much.
I think my only one addendum to, I agree completely with Jem, a very broad term for psychiatric illness, but it would be nice to maybe try to capture suicide attempt or suicidal ideation. And I think patients are pretty forthcoming with that. So
Right. That's pretty much a self-reported, somebody cut their wrist and you're there and, you
they
know.
say they were trying to hurt themselves. So maybe suicide attempt and suicidal ideation could stay as a separate category from other psychiatric illness.
Okay, you feel good about that one? All right, I am checking because I remember that David Fortino did something in response, and now I'm trying to remember what, and to see if there was any follow-up that needed to happen around that.
What did David do?
Oh.
David, you did
No, I
something
submitted
today.
our residential treatment reporting that we report to the state for you to review and see if there was data from that you wanted to collect.
Thank you. I did remember that you sent us something. Did we have a chance to review that at HFPD or not yet?
Amy, are you there? Amy compared it to with some of the data that I don't know if she's still there. A lot of the data it looked like was similar data that we're getting from Believe in Recovery and what's the other program? I'm just drawing a complete blank. It looked like it was very similar data to that. Is that accurate, David?
Likely, if she's reporting it already, that it would be similar.
And so that was, go ahead, Laura.
So it makes sense then. I'm betting, David, that your data is thorough. Do I have that right? If I were to take it from one or the other, which is going to be the best? Do I have that right, Lisa?
That's what I was wondering is if we wanted to just get it directly from.
Do we want it from Gabby or do we want it from you? Which do you think is the better?
Yeah, Amy's saying the same thing. That's what I thought. So yeah.
I know that Gabby also does some work with 0.1%. I know she gets some funding to do some assessments from there. And so I don't know if some of that information that she's providing you is overlap between the two, or if she's differentiating between those two programs that she's doing. The data that I would provide you would strictly just be our RSAT program. I wouldn't have any involvement with her 0.1% grant that she's receiving. So
it sounds like the action out of that would be for us to ask Gabby to separate out what's specific to 0.1% funding to use your RSAT data for the RSAT program. And then we've got no duplication, one hopes, and better accounting across the board.
I think that makes the most sense. Yeah. And we could circle back. And
I know we had on the agenda to talk about next steps toward training staff on coding. It feels like we've got a little bit of road to run before we get there. So I'm going to table that item unless somebody told me they'd like to run down there. Okay. R.E.A.L data, Dr. Carlo?
Just a quick question. I know you've been asked to provide funding to train people. I think this is internal training as far as how, as the NPD, I ask people to code charts. So I'm not sure. I think there will be training, obviously, that will need to happen. But I feel like that's my burden to care for, just so that we're clear.
Okay, and I want to maybe just give a little insight. There was a point there where one of the fire districts was asking for some funding for training for the BHC to help them connect with funding for training. And it would make sense if we were going to fund any one fire and rescue that we would want to fund all of our folks across this side of the county for those, whatever it was that we're kind of going to come up with to train for. So I think what I hear you saying, Dr. Karlbaum, is we won't need funding for the training that we're talking about here related to improving our coding practices.
No, I don't think so. I'll make some slides for people and talk about it at one of our countywide training meetings for EMS.
Okay, that sounds good. Any other questions around that topic? Okay, Jolene gave us a quick overview, but I'm just going to open it up. Jolene, you were talking about real data, and there's been some evolution in what's going to be collected, and tell us what the scoop is.
We just know that there's going to be a change in what they request. It should be fairly limited. I guess one of the questions I would have related to R.E.A.L is what is it that you are looking for from the R.E.A.L program data? Like, what would this group want to know before I can really say yes or no? I mean, some of the challenges that we all know with data in Jefferson County is the small numbers. And so kind of want to be clear on what it is you would want from the R.E.A.L program itself.
So perhaps for the sake of our two data folks, do you want to give just a little overview of the R.E.A.L data, what they'll be doing, who they'll be doing it with?
So who's being served by the program?
Who's being served?
Okay.
Because I don't think that they've heard the R.E.A.L data
Okay.
spiel or the R.E.A.L program spiel.
The R.E.A.L spiel. I'm sure
R.E.A.L
some of these
spiel.
have. We've been R.E.A.L spieling everywhere. And if you haven't, please reach out. We'd love to R.E.A.L spiel with you. So this program is intended to kind of fill gaps for individuals who have substance use or co-occurring contacts. And these are the priority populations, individuals who have frequent law enforcement contact or recent law enforcement contact, and individuals who have challenges engaging in systems and being successful with their recovery related to kind of a traditional service model. So folks who have been engaged in treatment several times, haven't finished, haven't been successful, have run up against other barriers. So that's the population that is priority. Ultimately, anyone in need. The program serves those individuals from where they're at. It is a peer focused response, so staffed with individuals with lived experience. So we are really collecting the data around who we're serving, how many folks we're serving, probably number of contacts each of those folks may have over time. This program is not time limited. So an individual could have a few contacts and be done with this program, or they could, next year still be enrolled based on what their needs are and their progression. It is also driven by the needs of the individual. So the individual identifies what their goals are. It is not driven by, the judge over there said I need to get sober. So it is very client focused and meeting individuals where they're at. And so, yeah, the data is pretty straightforward with how often, who they're referring to, who they're getting referrals from, those kinds of things. We accept referrals. A priority is law enforcement, but the referrals can be accepted by community members, families. We even have individuals self-refer.
So when I think about it from my seat, what I'm interested in is, and I want other people to speak up here, what I'm interested in is how is the R.E.A.L program ultimately, if we have however many visits with an individual, at what stage are we making sure that we've caught them there instead of at the law enforcement side? Does that make sense? Are we engaging enough with somebody through the R.E.A.L program that we are circumventing them needing to get to the we're intercepting them before they get to using an emergency room or a law enforcement situation? That's my first thought, but I welcome other people's input and insight to what you think maybe we should be thinking about here.
Well, my first concern would be privacy, because we cannot share kind of individual information related to how they're interacting with those systems.
Can we get disposition data? We've 18 times visited. I'm asking this because I remember Dan Montana had data with the program that he was doing over in Clallam. I don't think there was any identity related to it, but he could show that they'd had 10 visits over however period of time. It then went down significantly to less visits, and then they have not interacted with law enforcement or EMS, in so long of a period of time, which if you compared it to last year was much more. That's a very vague overview of the cool things that it looked like he was proving, that God, that would look good.
Yeah, I think, again, the challenge is respecting people's privacy, especially within Jefferson County with the small numbers. If we have, 20 people enrolled in this program, it'll be pretty easy for somebody to identify that individual if we say they've had this many contacts. So we really can look at kind of more general contacts related to the program, and de-identification is again a challenge. So, and we also, have much more strict privacy requirements related to PHI and our contracts at the healthcare authority level. So we would have to look at that more closely with a specific ask on a certain type of data, if that makes sense.
Any other thoughts?
So my thoughts on a high level would be that it would be great. These are just from the little bit you said, like, what are the referral sources that brought them into the program? What are the, and this I think could be done in an aggregate, out of the 15 referrals that came forward, 12 were from law enforcement, so-and-so were from this. Of those, 50% of people were referred to this kind of treatment or this kind of housing, or whatever those things are. And I don't know if on average you could say on average the group had this many visits. So it gets to kind of what Lori is saying, is trying to gauge over time how those things are changing. Are we getting less referrals from law enforcement and more from other places as we go? So instead of it being specific to an individual, looking at the program as a whole, what are the referrals coming in? What are the referrals going out? And also, I'd love to get this mix of what are the challenges that they're facing. Is it
The reason for
opioids?
referral.
Yeah, yeah. So back to our other discussion, so we can continue to kind of look at where they're coming from and where there could be potential. Sorry, what's the word I'm looking for? Duplication. If we're looking at law enforcement plus, if they're coming from law enforcement, and we're counting those people in law enforcement, like how does that? How do we kind of control for that? So those are my big thoughts about what we want to see from an aggregate level that might address some of your concerns with looking at individual episodes or patients.
Does that seem reasonable, Jolene? I mean, I know we don't know yet,
Yeah,
but what we're thinking about.
but
Okay.
yes, we do know we will be collecting some basic information on referral. Response times will be part of the information. So how quickly the team gets out there, and that may indicate how effective the intervention is and the need for referral as well. So we definitely will be able to do some of that more aggregate. Yeah.
Julie, I agree with Lori. I would love more specific data to show that, you made this intervention and outcomes where patients receive care in less than ideal situations goes down. But I understand the limitations of data. I wonder if, in addition to Lisa sort of coming into the program data, if there's sort of criteria for graduation from the program and showing that, it took 18 visits for people to graduate, or of the people with unstable housing, 50% achieved stable housing after X number of visits. Of the people with substance use disorder, X number said that they, were not using substances after X number of visits. Some more sort of outcome data to measure impact, because I think, demonstrating impact would be helpful.
Yeah, I think that definitely we can look at some outcome data as well. I think one of the challenges that I kind of see off the bat is somebody may come in and they may qualify in probably 10 different categories of need. And so how we then sort how those outcomes are impacted, because we're going to take those as they come. And so the priority of what is being worked on may change. It's not likely an individual will come in and say, I just need housing, and then we would help them with housing, and know that in 6 visits they would, they might come in today for housing and next week they don't have any food and need some help with a different issue, and then they have to go to detox, and then they're back to treatment. And but we definitely can look at that and see how we can sort that in a way that would be useful.
Yeah, and you do bring up a good point of having some descriptive statistics about, on average, individuals have needs in 6 domains or 10 domains or whatever.
Thanks, Jolene. Other thoughts on that topic? Okay, one of the things that we touched upon last time we met together was the possibility of tracking stable and unstable housing. And I know that there was maybe some exploration that was going to go on. Did folks have time to look at that at all?
We did from a law enforcement point of view, and we couldn't figure out a good way to be able to do that. The problem is that most of our incidents that you see in those data groups, they don't, we don't typically collect an individual's address information within that type of call, especially with mental health and drug addiction. Because some of these, let's just say half of these incidents involve people who are cooperative and the other half involve people who are not cooperative. Where, EMS and hospital, they mainly get the cooperative patients. A lot of them that are uncooperative, they obviously get some, but I'm guessing that number is a little less percentage wise. So at least in the law enforcement perspective, I can give you maybe addresses for people that are transient in nature, but I don't think it would be very accurate comparing the incidents that we're giving you. I don't think it would be helpful in a law enforcement perspective. I don't know about the jail. I'll let David comment about that.
We just go by what information the individuals give us at the time of booking, which is not very accurate. They often tell us they don't have an address or give us the wrong address. So I would say our information is not the most reliable. It's just another data point we collect and use for our agency at times.
Well, thank you guys for exploring it. I know it was something you put out there. Lisa, were you thinking something there? I thought maybe I saw you like that.
Yeah, well, this is where it's great to have all these different people at the table, because I think that's where Jolene's data can help us as we see, as we're interacting with them in a different level, and they're asking for help with housing, hopefully that can start build this database about how many of the individuals we're encountering have issues with housing. I mean, it'll be another look at that, where people are, again, in a different role with the patients than they are when they're dealing with them with the law enforcement or the jail. So, I mean, I think it's a little bit of a puzzle that we're putting together, but I think adding that real data into it will be helpful.
Okay, I'm just looking over into the chat box. Sorry, Dunya, I didn't see when you put in there that the RE.A.L acronym is also used to describe race, ethnicity, age, and language. So we should be aware as we're speaking, maybe to, and I forget, it's recovery, advocacy.
Recovery, empowerment, advocacy, and program. So RE.A.L program might be the better way to
RE.A.L program.
separate that from.
Okay.
Yes.
Recovery, empowerment, advocacy, linkage.
Yes.
Program. Got it. Got it. Okay. I don't have anything else on the agenda except to talk about some PIMS report data, which maybe not everybody on this call is interested in. But before I go there, I wanted to see if there's anything else this group would like to discuss with each other. Go ahead, Brett.
So just so you know, I know I saw cringes on data changes, but we are having a data change here coming up later this month. So we're merging our system along with PENCOM. So a lot of those calls for service are going to change, like the names of them and stuff. And it'll be a little bit harder to get historical, maybe. David especially, because his program changed significantly compared to ours. We'll still be able to get it. It just may be a little bit different. So just be prepared for that.
Okay, any questions around that?
Brett, is this around the dispatch system upgrade at JeffCom?
Yes, so yeah, we're merging all of our data in with PENCOM. So we just kind of had to agree to what call types were and stuff like that. So it sometimes takes a little while for David and I to try to figure that out. So.
Got it. Is there anything, I meet monthly with Stacy, the director of JeffCom. Is there anything I can do to advocate for y'all?
No, I think it's going well. It's just going to change is all. So there's nothing that we can do other than wait for the day to come and start learning it from that day on. So
I'll remind her maybe about historical data and ask how she's going to have a snapshot of that when the old system shuts down so that it can still be accessed.
So it can. So all of our historical data is coming over to the system. It just, they reorganized it. So that's the problem. You know, like our call types might have changed from drug to, you know, drug abuse and something else. So that might be a problem, you know, especially in Excel spreadsheets, if you're trying to, you know, compare calls for service by names and stuff. So the historical data will be there. It's just going to be labeled a bit differently.
Got it. Thanks. Sorry, I was confused.
So
maybe when we- go ahead.
Sorry,
Please.
Lori.
Go ahead, Lisa.
I don't know how to do the raise your hand function, so gotta figure that out before the next call. So that is an interesting, we'll just have to look at that as far as these groupings. And again, I think it's a matter of making sure that if we group anything that we're getting in the future in a certain way that you're all comfortable that we're putting it into the right grouping if it's changed. I think the large groupings are one thing, but it's when we start getting into trying to refine these a little bit, just making sure that we have feedback from you if things are different. And maybe we can, once you see what the new system's gonna look like, we could just kind of look at it side by side and figure out how to, because we could even clean up the historical data to be more consistent moving forward. So we have a more consistent comparison moving forward. But
I love the idea of cleaning it up so that historically we're on the same framework. Yeah. Okay, any other thoughts? I think I might even be letting some of you out early. If anybody would like to stay and talk about the PIMS report, that's probably a 5-minute conversation. I welcome it now, or I'll probably be reaching out to those of you that impacts individually. So I think, Brett, that would not impact you. Jolene, not you. Thank you, Brett. Appreciate you being here. Lisa and Amy, not you. I think I've already talked a tad with Adam and Dunya about it. Okay, so the highlights on the PIMS report is that, so this is the report that we put into HRSA every quarter, then they moved it down to every 6 months. And then this particular time frame, they have now evolved the performance measures that they're tracking, and they changed the whole set of spreadsheets. So I discovered was this massive amount of rework that I need to do of all the basic information. And then I will likely need to talk with all of the individuals who are contributing data to that PIMS report, which is DBH, the hospital, public health, couple more, Recovery Cafe, put some in there, Believe in Recovery, used to be Safe Harbor, but now I'll get that from DBH. So our dream is to keep, because we collect this encounter sort of focused, resource intensive, focused data that HFPD has been analyzing for us all along. We've kept it so that the cadence of that data collection and the data collection for the PIMS has been happening at the same time, so that we had all of the data at once and we could have HFPD present that collective insight presentation back to the group, you know, within a month or two after each PIMS report. We're hoping to keep ourselves on that same schedule this time around. So I'm going to try to work with folks to get that data by, you know, the 3rd week in March. It's just going to be a little bit of interaction between all of us, so that we address what it is that HRSA has evolved. And I think we should all cross our fingers that they don't evolve something again next year, because it's such a pain in the butt every time they do it. So that's what I've got on PIMS. Any questions? I'll be reaching out to you individually if I typically get data from you. Jim, Tanya, I know you had some questions maybe about the SUD funding. We can talk about that on a call separately. Dunya, Adam, any other questions? Good.
We're planning on talking to you next week.
And I apologize for the 18 invitations you had for me to talk about all one and the same thing.
No worries.
All right. All right. So thank you, everybody. I appreciate your time and have a great afternoon. Bye, Jim. So let's see. Amy, Lisa, any thoughts as we think about what we're going to be doing after that meeting? I guess not.